We are going live in 5 seconds. 5, 4, 3, 2, 1. Sir, we are live now. Now we can start.
Yeah, thank you, Maharshi and OrthoTV, and I welcome you all to Orthokids Fellows Teaching Module. And today, in this deformity correction module, we have one of our dear friend, colleague, and who has made this POSNA Alliance so live and gave us an opportunity to learn different topics from the stalwarts of the field, none other than Dr. Sanjeev Sabharwal. Thanks, Sanjeev, for accepting our invitation. And I would like Goda to introduce Dr. Sabharwal and start the session for today.
Yes, sir.
Dr. Sanjeev, you might have to stop sharing your screen so that Goda can share her screen.
Okay. Sorry about that.
Yeah, it's okay.
Yes, sir. Good morning. Are you able to see my screen, sir? Yeah.
Not yet. In a minute, probably.
A minute, sir.
Yeah, Goda, you can share your screen.
Yes, sir. Yes, sir. Is my screen visible, sir?
Yes.
Yeah. Good morning, everyone. Today we have our stalwart Dr. Sanjeev Sabharwal, sir, who's going to speak on advances in limb lengthening and deformity correction. Sir is a consultant pediatric orthopedic surgeon and head of limb lengthening and complex reconstruction center at UCSF Benioff Hospital. He's the program director for pediatric orthopedic fellowships as well. His areas of interest are limb deformity, skeletal trauma, and he's an expert in limb reconstruction. Sir has done his MBBS from Maulana Azad Medical College and residency in general surgery at Mercy Health St. Elizabeth Youngstown Hospital and residency in orthopedics at University of British Columbia. Sir has done various fellowships, and his pediatric orthopedic fellowships were at Children's Hospital, Los Angeles, Shriners Hospital. He's also done his fellowship in limb lengthening and reconstruction at ICLA. So has been the past president of Limb Lengthening and Reconstruction Society. He's been an examiner for American Board of Orthopedic Surgery since 2010. He's the deputy editor of Journal of Bone and Joint Surgery. And Sir is an editor of his famous book for lower limb deformity correction in children. Thank you, Sir, for accepting our invitation for today's talk.
Yeah. Thank you, Goda, and thank you, Molin, for the kind invitation. It's really a pleasure to be back, at least virtually, and I'm sure we're going to see you again in Ahmedabad. So I look forward to that. Okay, so let me see if I can share screen. And Molin, is this working? You can see it?
Yes.
Okay.
Yeah, we can see.
Okay. And again, I don't know how many people are on this. So Molin told me it's, mostly it's going to be trainees, postgraduate trainees, and young surgeons. And I want to keep this relatively interactive and case-based. So, and my assumption is that you've already had some talks and seminars on the basics of limb lengthening, deformity analysis, and principles of deformity correction. So with that as an assumption, I'm going to talk a little bit about advances. And really, sometimes advances are really, just going full circle and you come back to square one. So, you can't ever forget the basics, and you have to be rooted in, sound principles, no matter what implant or which part of the world you practice in. So that part doesn't change. So let me see if I can advance this. Oh, sorry. Let me go back. Okay, so these are my disclosures. And by the way, just a plug, we are bringing out our second edition of the PEDS Limb Deformity book, hopefully in the next few months. So I'm going to start with some case-based discussion. And again, anybody, and either Molin or Goda can, serve as a moderator. If people have questions, they can either raise their hands or speak up or put something in the chat, and I'd be happy to answer. or we can sort of do it at the end of the talk or after a case or two.
Right. Yeah.
Okay. So let's start with and these are all cases that I've had in the past few years. So these are relatively recent, in the last 5 years or so, I think. So this is a 16-year-old female who presented with lower limb deformities and leg length discrepancy, right shorter than left. She had a known history of hypophosphatemic rickets with sort of classic deformities. When you look at the deformity analysis, and again, I'm assuming you've gone through some of this in the previous sessions. So she was treated elsewhere before, had attempts at guided growth, which was appropriate, and now presented with bilateral genu varum, right worse than left, and shortening, again, right shorter than left, with a multiplanar deformity. You could see in the femur, she's got varus and apex anterior or procurvatum, and those are some of the numbers just of the right side. In the tibia also, she's got varus and procurvatum. So I don't know, maybe, Malin, should I just stop here and ask people what they'll do or keep going?
Yeah. So, Goda, what would be, how would you manage?
Yes, sir.
The questions
So-
is let's focus on femur first.
Yes, sir. So, sir, what I would like to do is, we have a scanogram in front of us. So I would like to measure the joint angles first, know where the deformity is coming from. So I would like to know the LDFA, which we have over here is 97. So the normal value is 87. So we know that the MPTA is 73. So we have deformity in the femur as well as in the tibia. So now I know that where the deformity, as well as we have a procurvatum as well. So since I know where the deformity is arising from, I would like to know the corana, where I need to plan my osteotomy levels and then go about.
Okay, so
Right.
that's great. And you've got, in the center picture and the far right picture, you've sort of got a little bit of the anatomic axis planning for the femur.
Yes.
And so you can see there are two apices, a little bit different levels, one in the
Yes.
distal femur and then sort of mid shaft on the sagittal plane. So what's your plan for that then? So let me ask you questions then. And by the way, since we're just doing the femur, that's great, but ultimately we've got to sort out the whole limb, right?
Yeah.
Yes.
So for the femur then, options are 1 level, 2 level. What's the technique for osteotomy and what kind of implant choices?
So implant choice, when I've seen the clinical picture, she has some amount of shortening as well. So
Yeah.
I think we can go for this case, a femur nailing would do instead of an external fixator and a gradual correction.
Okay. And how would you do the nailing and what are the pitfalls?
I think this would require like multiple osteotomies if we plan for nailing, sir. So,
Okay. And would you go antegrade or retrograde?
antegrade, sir.
Okay. Any other thoughts,
So-
questions?
The other option would be an external fixator based correction.
Okay. What
Gradual
does that
correction.
mean?
Yeah,
Okay.
gradual correction. Yeah.
Uh-huh.
Again,
what
the
are the-
issue, yeah.
Go ahead, Malin.
Yeah, so issue of nailing again here is the trochanteric entry nail. So we have to check the length of the femur. Sometimes the shortest nail available in India will not fit femoral nail. So we end up sometimes using a tibial interlock or humeral interlock nails for this. So whenever we are planning nail, we must have all the sizes available. And we should not resort only to femur antegrade nails. We might have some issues of the size. So that's one. Yeah.
That's a great point. Great point, especially in patients with skeletal dysplasia, short stature, And, we're not talking about everything, but, somebody with metabolic bone disease, you just have to optimize them metabolically as well, preoperatively, etc. So, okay. So any thoughts on the tibia? And the ankle, you see, she also has a varus. Her lateral distal tibial angle was what, 107?
7, yes.
Yeah.
So she's got, go ahead.
So the cora of tibial deformity is at proximal tibial metaphysis. Or
Yes,
could
let's
you make?
assume. Yep.
Yeah.
And that's a single level for
Yeah.
both the frontal and sagittal. Yeah.
So one plan can be you correct the femur acutely with an intramedullary nail, and then you correct the tibia deformity as well as you can lengthen it from the proximal tibia to equalize the limb length. So that can be one option,
Yeah.
Because in femur we are dealing with a double procurvatum as well as varus.
Yeah.
We can do it with fixators as well, but these are different options. You can see in the proximal tibia there is a tibial slope issue is also there. So it would be wise to correct that slope with a frame and lengthen it simultaneously.
Yeah, good point. And also she's got some tibial torsion, right? Internal tibial torsion. Her clinically her thigh foot angle was 20 degrees internal on the right.
So Dr. Gaurav is asking that whether this discrepancy in length is from femur or tibia, that would can we measure that and can we address that accordingly?
Yeah, I think, if you look at this full length x-ray, I think it's sort of half and half. Some is coming from the femur, some is from the tibia. And you're right. Ideally, you'd like to make everything equal, knee joint at the same level. But sometimes you make compromises based on, other issues like you mentioned, Malin. So, okay, just so that we can move on. This was great discussion, by the way. So, by the way, these were her x-ray standing. And if you go back, I kind of made the decision when you look at her clinically from behind, her hind foot is not in that much varus. So it's probably because the subtalar joint has accommodated over the years for, her distal tibial varus. So I elected not to complicate things too much by adding another osteotomy at the distal tibia. So I kind of listened to both of you, and so yeah, these were the things. We never talked about clamshell, but we could talk about it in a minute. And I think we've sort of, you both have nicely brought out all these issues. So we kind of did this fixator-assisted intramedullary two-level, correction. So use a fixator, percutaneous osteotomies. Those other incisions are to just remove the hardware, which was already there. And then, maybe use a blocking screw there. And you could see the marks from the fixator that was done intraoperatively. And just like you said, gradually corrected the tibia to realign her axis. And then here she is in sort of the consolidation phase, with a reasonable outcome on the right leg. So just for the sake of time, let's go to the left side. And so here she is, after healing the right side. Now on the left, she kind of has a little bit of a different story. It doesn't look as bad. It isn't as bad. Her leg lengths are getting close to equal. And it's a little deceiving because in the femur, she's got, a mid-shaft, slight valgus, but a lot of apex anterior angulation, and then a little bit of distal femoral varus as well. And then in the tibia, he's got, again, primarily a little procurvatum and a tiny bit of varus, I think. So what are your thoughts for this one?
So again, what first I would ask is, many a times it happens so that limb looks shorter at the outset. And once we correct the deformities, the length becomes equal. No, the shortening is usually many a times it's apparent and not a true shortening. So here, did you lengthen the tibia on the right side?
Yes, yes, yes. So here in the middle X-ray, she's actually standing on a 1.5 centimeter lift under the left foot. So to your point, when you correct the procurvatum, that gains some length. And of course, I didn't do any closing wedge osteotomies. These are all done percutaneously. So she certainly got some length there. Yes, but I must have lengthened her, I think, 2-ish centimeters, 2 to 3 centimeters. I can't remember.
So now she is short by how 1.5 centimeters, you say?
1.5 on the left side.
Yeah. So and there is this some tibia vara is there, right? The proximal
tibia
tibial
vera
varus.
and again procurvatum. Yeah.
So I think I would leave the femur alone and correct the tibia, and at that time I will gradually lengthen till the limbs might correct the deformity acutely and then lengthen till the limbs get aligned. That's I would deal with it.
Okay, so you would acutely correct the tibia and still lengthen?
Acutely correct the tibia and see how much discrepancy is there. If many a times with 1.5 centimeters with correction of tibia with a dome osteotomy or something that sort, if limb length is equalized, then you may avoid lengthening. But if you want, so I'll take judgment after correcting the deformity.
But then, aren't you like already committed? If you did the dome osteotomy, you've got everything open, and then, and not to put you on the spot, but just to carry on the discussion. So then, how aren't you like too far in the case and committed to an open procedure, and then you would put on an external fixator to lengthen?
Yes. So what I meant is I would put a fixator, osteotomy fixed with fixator, and keep an option open of lengthening if needed. If not needed, so I will temporarily fix this via the K-wire and see whether length is aligned or not. I mean, length is equalized or not. If it is equalized, then I'll fix it with a plate. If it not, then I'll put a fixator and lengthen it. Acute correction and lengthening.
Okay. And how accurate do you think is leg length analysis, supine, on table?
Yeah, that's why it's tricky. I agree with you. That's why putting a fixator would be a better choice than a definite plate fixation. Goda, do you have any other idea? Would you do anything else different than this?
Yes, sir. So, since we've corrected the opposite femur as well, I feel we need to correct this procurvatum in the femur also with multi-level osteotomies and nailing, followed by gradual correction with a fixator in tibia, which even gives us lengthening. So
why you want to correct the femur here? Or I would ask Dr. Sabharwal, the joint orientation lines are okay. And there is a we see a lot of hypophosphatemic children who have diaphyseal deformity without any long-standing problem. Dr. Sabharwal, what is your take?
Yeah. So, I kind of struggled with that same issue myself. I was trying to talk myself out of doing anything with the femur, just like Malin, you were thinking. And then I just looked hard and I thought of a young, healthy 16-year-old and what is the knee joint going to look like in a few years with, the kind of forces that will be there and also the patellofemoral joint. So, but I agree with you. And I mean, for the trainees, this is a classic problem with the femur in a growing child, that there are compensatory deformities which kind of make the femur look okay, at least on the AP. But if you were to do kind of the multi-segmental analysis, you could see, or you can't see that clearly, but if you really drew all the lines and angles, that she indeed did have a little bit of valgus procurvatum, not a little, a lot of procurvatum and a little valgus in the midshaft, and a mild to moderate varus in the distal femur. So again, just to, I honestly think both approaches are reasonable. And by the way, Goda, what would your implant selection be for the left femur if you did the osteotomies?
Implant selection. So I would go for an intramedullary nail itself, so with the same blocking screws. Trochanteric and antegrade.
Okay. Antegrade. Okay. So the one other thing, and of course, you don't have all the lines for the left side, so that's a problem here. But her cora or her apex
Is
distally was pretty distal. And so, the issue is, can you really correct that osteotomy and stabilize it well enough with an antegrade nail?
okay, sir.
So I
I
think
don't
with
think
that,
so, sir. If it's that distal, retrograde.
Yeah.
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 Okay.
So that's why we chose a retrograde nail and tried to correct, both deformities. And then, just like we were saying, we did the tibia gradually, like Marlon was suggesting. And so then here she is, in follow-up after both sides with restoration of length, mechanical axis, and we've sort of restored her at least mechanically. And by the way, hypophosphatemic rickets patients do heal slower than usual. So
Yeah.
it took her longer than usual to heal the tibial osteotomies, despite me going slowly. So just another word of caution. But interestingly, her fingers healed fine, fast.
Yeah. So, Dr. Sabharwal, one question, like you have huge experience and you have been doing this corrections for many years now. Have you seen patients who have not followed your surgical advice and they ended up into early arthritis, and your joint replacement colleagues told you that this patient, which you treated initially, now I'm doing early knee replacement?
No, Molin. I mean, again,
Uh,
great question, but somehow I mean, you have a point. Like, this happens a lot with skeletal dysplasias, like achondroplasia. We know,
yeah.
despite having genu varum, they don't seem to have arthritis. So the honest truth is, I don't remember, definitely don't
Yeah.
remember a patient with hypophosphatemic rickets with that outcome. But, my experience is skewed because I probably operate on a lot of these deformities. So I don't have the luxury of looking at the natural history.
Controls, yeah.
Yeah.
Dr. Vasudevan demonstrated a few cases because he's doing pediatric as well as adult deformity corrections.
Mhm.
But most of the times, these hypophosphatemic rickets patients are quite exhausted with medical therapy and then multiple interventions.
Yeah.
Anyways, but this is for the point which is to be learned, that we have to correct the deformity in both the planes and to align the joint for a better long-term outcome. Yeah.
Okay.
Any questions for this case before we start? Retrograde femur nailing and percutaneous only in femur. That's, yeah, Puneet, that's what has been done. Gaurav is asking, what is the effect of shift in knee joint line and how much it is acceptable? Dr.
What do you mean?
Sabharwal.
I'm sorry, you mean like pre-op or post-op?
Pre-op. If we just accept it, then how much of anatomic axis or joint line disorientation is acceptable?
Yeah. Okay. So I guess those can be answered many different ways. But if you just, because as you know, there's the concept of alignment and malorientation. So alignment simply means, center of the head of the femur to center of the head of to the tibial plafond. Where is the mechanical axis? So in this one, the mechanical axis, and you can quantify that either in millimeters, degrees, or quadrants, right? Or so this I would say is, or zones rather, like zone 2/3. So zone 1, as you know, is sort of the central half, then medial lateral, and then anything beyond the joint, if the mechanical axis falls further away, varus valgus, that's zone 3. So this, to me, if a mechanical axis doesn't touch the bone, I think that needs to be
we corrected, yeah.
right?
And another question is, if we use an fixator assisted correction in femur, do you see more knee stiffness compared to when we do it with proximal tibia, or a nail is
No.
better than fixator?
Oh yeah. So I think those are two different concepts, right? Using fixator assisted nailing mean the patient wakes up without a fixator, right? So that has, I think, no bearing on knee motion in terms of having half pins going through the quads. But, having a fixator that the patient keeps on for several weeks to months, definitely, even in the best of hands with the best of therapy, can be, can lead to some loss of temporary knee joint motion, and you got to work hard at it. So definitely, that's an issue, but doesn't mean that you should stop doing all external fixators for femurs, because sometimes you go to these meetings, and especially the Western speakers will say, oh, with pride, that I haven't really put an X-fix on a femur for 10 years or something. To me, that is not the right message. I think based on your skill set and what the patient needs, you got to do what you're comfortable with, and you know how to bail yourself out of trouble. And what is, financially a viable option for the patient and you. So I don't, again, it's all principle based, as long as you understand, because you can mess up the magnetic nail as easily as you can mess up an external fixator lengthening. So it's not that you use a magnetic nail and everything's going to be golden. So it's really not that.
One more direct question, in your experience, when you couple deformity correction and lengthening for femur, in what percentage of patients you need some secondary procedure to improve the knee range of motion? I mean,
So
quadricep lengthening.
if you're talking about, with internal lengthening nails?
No, I'm talking about the fixators. We use Ilizero or this hexapod to correct the deformity as well as lengthening.
In the femur.
Have seen in the femur, we have seen a lot of patients with stiffness, and some of them, they need quadricep plasty. So what is the rate? What's your experience in it?
Yeah, well, I'll show you I don't know if you'll have time, but I can show you a patient where that was the case. But so it's again, depends on how much you're lengthening, how you're putting the fixator, how much therapy the patient's getting, et cetera, et cetera. So I agree. I would say, if I was to be honest, and I don't do, well, certainly not now, I don't do a lot of external fixator lengthenings, but if I put my cumulative experience over the years, I think the incidence is probably 5%, maybe. I don't think it's in double digits, but it's definitely not 0%. So I would, and the two that I distinctly remember were both like Ilizarov hip reconstruction with, 2-level osteotomies and lengthening. Those patients almost predictably, in my experience, needed a quadriceps plasty. But for straight femoral lengthenings with moderate, like 3 to 5 centimeters, I think if you do other things right and there's not a major issue, I think it's not that common in my practice.
Right.
Okay, should we keep going?
Yeah.
Okay. And so, just another option, so the clamshell osteotomy for a multi-apical deformity for same patient, hypophosphatemic rickets, is another option. If somebody's comfortable with nailing and doesn't want to do these percutaneous osteotomies, there's a slightly bigger operation, but it's a very, as long as the two ends of the femur are not mal-oriented, and the midshaft can have, 5 different deformities. This is a very elegant solution. So, I did this and this was probably more than, this case was older, but I did this, with a clamshell. And, so again, using a femoral distractor, very similar kind of patient. So just to show you that that's another way to deal with, a multi-apical deformity in a skeletally mature patient. Yeah.
Right.
Okay. All right, let's keep going. Okay, so this is an interesting one, which I think goes back to principles. So it's a sad story. 11-year-old girl came to me for really a second or a third opinion with a leg length difference. And as an infant, when she was 6 months old, she had a hernia operation. And unfortunately, the surgeon tied off the femoral nerve or injured the femoral nerve. And that wasn't diagnosed for, a couple of years, I think. And then she had a nerve grafting and this and that. And so now she's here at age 11 with really no quadriceps function, still ambulating, but starting to trip and fall, and with a leg length discrepancy and a flexion deformity at the knee. And let me see if I have another picture. Here we go. Okay. And that's her x-rays standing on, I don't know, it says 3 centimeters. So she's like got 4.5 centimeters of shortening, valgus, and you can see the full length lateral of the left femur and the right femur. So any thoughts, suggestions? What's the, let's make a problem list and then tell me what thoughts you have to help her.
Yeah, so any takers here? Dr. Anil is here. Gaurav, you want to talk? Yeah, if not, Goda is there always. Goda, you want to take it?
Yeah, sir. So the problems here are, firstly, shortening is there. She has very poor quadriceps mechanism. Hello. Sorry.
Yeah.
So
yeah.
as well as very thin medullary canals. So I do not know if we can go for intramedullary lengthening in this case.
How about the joint orientation at the knee? Is patella?
The patella
Sanjeev?
is, there's a little bit of patella baja. You can see that, right?
Yeah.
And you can even look at the soft tissues of the left versus right, and you can see
there's no quads at all.
Yes.
There's no quads, right? So the question is, first, let's go biomechanically, and this is not that different from a post-polio situation, right?
Yes.
If you've got a weak or absent quads and a flexion deformity, and let's say you start lengthening the femur and you make her leg lengths equal, what do you think is going to happen to her function?
So she'll have more knee flexion deformity.
Yeah.
And her gait would be a bit challenging because they need locking of knee to walk, yeah?
Yes, exactly. So unfortunately, I mean, that was what was recommended for her, was that let's lengthen the femur because the femur is short. And, so, but that I agree with you, that probably would not be the first choice, because you got to then, look at, like you rightly said, you need to, if somebody has weak or no quads, they would need to lock their knee in extension in the mid stance so they don't trip or fall, or have like a hand thrust gait to push the femur back, right?
Yeah.
So, and then she's got a little valgus too. So tell me, what should we do?
How about a supracondylar extension osteotomy? Would that work in this case of a hand to knee gait?
I think so, because that's what I did too. So, okay. So these are the things we talked about, right? And we also said that if you just lengthen, then, it's gonna, then the question is, Goda, how would you address her leg length difference?
Leg length difference. So for her weak quads, as we thought, supracondylar extension osteotomy, and for lengthening, I think a fixator-based tibial lengthening.
Okay, so you're not worried about a mismatch of the femur knee joint axis, or I mean levels rather.
Not much in this case, though.
So again, like one more option can be, Dr. Sabharwal, we can correct the femur and lengthen it, and we can do the hams to H2Q transfer, which we used to do in polio. So that will take care of knee flexion deformity at the same time give some quads power. Can that be done? That's just a hypothetical.
Yeah. So would you do the tendon transfer like as a second stage after
Yeah.
correction and then okay.
Yeah,
Yeah.
that's what
I don't have much. Yeah, I have really no experience in this kind of patient.
Even we also don't have now. I have done couple in kind of amyoplasia patients with adult colleagues who had great experience in polio, but not in such cases.
Yeah. So, I mean, again, this is a little biomechanically, it may be similar to polio, but it's different because when we went in, her quadriceps was just like a sheet of fibrous tissue. It was nothing. So, and that's kind of what happened. So just for the sake of time, I'll move on. And she had a little bit of a valgus as well. So just like Goda was saying, we did, I don't know if you want it a fixator assisted or not, but we did, and just so that we don't stretch her soft tissues anymore and we could deal with length later, we did a closing wedge to kind of optimize bone healing, faster healing, etc., with the plan for secondary, lengthening, integrate. So this is just a picture of like a, fixator, just a simple 2-pin fixator medially just to stabilize it, and then doing a closing wedge, and just putting a plate, and like you said, correct her both in the frontal and the sagittal plane, and in the sagittal plane, almost intentionally overcorrect her so that her knee is just past full extension. So we did that. And then, so here she is after that. Of course, she still has the shortening. The shortening actually got worse, predictably, but you could see on the standing x-ray that now at least her femorotibial alignment has been restored and she can lock her knee, although you could also see how distal that patella is. But the other thing which is reassuring is that she has regained full mobility, including full extension and flexion. And you could see the length of the scar, because I did do sort of a modified quadriceps plasty just to lift off the quads and, mobilize it as much as you can. So at this point, we then elected to go antegrade and, lengthen her with a magnetic nail. And, and I think, and again, not to sort of say that that's the only solution, but for people who have done both fixator lengthening and intramedullary lengthenings, it does, for the right patient, this is a game changer in terms of the speed with which patients get their knee motion back. Or, some of them never lose knee motion. So I think with the right support, right indications, I think it is a good option. But I tell you, like lengthening over nails is almost as good.
So this is one topic which we want to discuss in POSICON 25, that magnetic nail, lengthening over nails. The cost is a constraint at the moment. Only few doctors are doing, but I'm sure with more companies involving it, we'll have lesser implants available, lesser cost. And maybe this would be one of the topics when we do this conference.
I think that would be a great topic, and also sort of exactly that go beyond, like what would be the cost-effective solution? Because I mean, that is what it is. If you look at it globally, I think these kind of implants are needed in settings more often than not. So great topic, Molin. Okay, should we just keep going?
Yeah, that's a great case, this was.
Okay. So we could talk about trauma now, post-traumatic. So this is a girl who I didn't see or treat initially, was treated elsewhere, but appropriately, I think. Salter to distal femur, treated with, I think, close reduction and smooth pin fixation when she was 10 years old. And then I saw her, not even here, but somebody else had done guided growth, but it probably arrested the procurvatum from going any worse. But you could see she's got a significant,
physeal bar
and a physeal bar posteriorly. And so this is when I saw her, I think, for the first time. So she was 3.5 years, I can't read the top part, but anyway. So she has a flexion deformity. She's got a valgus. It's in the distal femur, and that's her max extension in the bottom left. So she's got a flexion deformity of the right knee. And so those are the numbers, right? About 6 centimeters of shortening, 43 degrees of procurvatum, 5 degrees of valgus, all coming from the femur. So what do you want to do?
So I think this degrees of procurvatum is not amenable for retrograde nail, right? And
Well,
so
I mean,
think,
yeah.
So this probably needs a fixator assisted deformity correction as well as lengthening. And maybe in future, this child might need some quadriceptoplasty if she remains stiffer, because this fixator would remain here for a long time.
Mhm.
So I would consider fixator assisted deformity correction and lengthening.
Okay, all together, right? Yeah.
Yeah.
Actually, that for those reasons, that was my plan. But this is, not every plan goes as wanting to be done. So yeah, we can go through these numbers pretty quickly, but nothing surprising here. So yeah, that was my plan. So this probably was one of my last external fixator lengthenings. But thankfully, I had it programmed. So I said, we'll do a little bit of, initial distraction and deformity correction, and then do further lengthening. And I think that's a pretty good strategy to adopt, because some of these patients, like this one, kind of decompensated. And she's like, I want this thing off now.
Yeah.
So I think if you want everything done, deformity and length, correct the deformity relatively quickly with gradual correction, obviously, and a little bit of lengthening. And then you can just do straight lengthening afterwards. Then I think that's a better strategy than not. So, because that's what happened with this one. And so here we may have just lengthened her about 1 centimeter. And by the way, this posterior translation is, intentional, because the physeal bar was distal, right? So you need to.
So cora is away from.
Yes. So anyway, so she hardly got any length, and got the fixator off. And I don't think I did a full quadriceps plasty, but I think her knee was stiff, and then I had to just kind of do some pin releases when taking the fixator off, and then ultimately, she gained length. So here she is a few years, or 2-3 years later, and so now her leg is straight and she's moving nicely, but she is 4.5 centimeters short. So what should we do now? And it's all coming in from the femur.
So I think we can now, in your setup you might have used this magnetic lengthening over the magnetic rod. There's a simple lengthening. I would use an LRS and lengthen it, and that can be done for proximal metaphysis. Goda, what would you do? Any other thought?
I agree with you, sir. We don't have access to lengthening nails, so we would do LRS. But then sir has access to lengthening nails precise. So maybe sir must have lengthened it over a nail. Lengthening.
The question is, Dr. Sabharwal, where we should stop. What should be the position of our distal pins? I think we should limit our pins into the proximal segment of, proximal to where you have corrected the deformity previously.
And where would you do the osteotomy?
I would do at a proximal diaphysis, more proximal than distal,
Yeah. So how about lengthening over a nail, like even a rush rod or an elastic nail?
That's what.
So
yes, sir.
So we have done that. The problem is, in this older children, the rod size is very is very small, So whether it helps you in taking off the fixator early or not, that's a question, you know.
Yeah.
You
Or you
understand
can
what I
use,
mean? Yeah.
yeah. Or use, like you were saying earlier, like a tibial nail, smaller diameter,
Yeah.
and then, you know, and just leave it nice and long, and then distally lock it after you've, yeah. So I think many options. You have to be a little creative. Okay. So yeah. So just like you were saying, yeah, we had the luxury to do this with a magnetic nail. But I tell you, and I've done maybe half a dozen of these patients where they've had a fixator in the past and then had a magnetic nail. And I haven't had an infection yet, but I think that can happen. And some people have had infections in patients who've previously had a, you know, external fixator, especially if there were major pin track problems. So, you know, and I think the same will go for lengthening over nails. Like if
Yeah.
you've had a previous fixator, just be careful and, you know, make sure that the pins are fine. Okay. So here she was, and you know, and I don't try to like just show pictures without good facts, but this was real. This was on her last day of distraction, and that was her knee motion. So I feel
Oh.
definitely if you can sort of not touch the soft tissue envelope for femur lengthenings, it definitely helps maintain knee motion. So I think that's something to sort of think about.
Yeah.
But these were, you know, all these other options. And I think each of these options would be fine. Is totally acceptable, you know, acute correction of the femur and proximal lengthening. I could have easily done that. And I may have done it had I known that, you know, she's going to decompensate with a fixator. I
Right.
think if you really are trying to be brave and you want to do everything together, while it's going to be super challenging, you could theoretically do a retrograde nail with acute deformity correction, but that would not have been my first choice even today. And then, of course, gradual correction we did, and acute correction with a contralateral shortening is also another option. You know, somebody who doesn't want to undergo lengthening at all, you could just take 5 centimeters off the other femur and, you know, be done with it. Or just say you will correct your femur angular deformity and just use a shoe lift. So I think anything is reasonable based on, you know, patient and surgeon preference. And then, you know, if we're going to talk about, you know, what is an advance, since, you know, Malin wanted me to talk about advances, this is another thing that we've been talking with in the last year. It's called DTI, or diffusion tensor imaging. You may have heard about it. Neurosurgeons use it too for the spinal cord. But it's in a way, well, I don't think it's mainstream yet, but it is definitely a step in the right direction where you can gauge the functionality of the cells of the growth plate by doing some sort of software manipulation on MR sequences. And so our radiologists are now able to sort of streak these growth plate cells and look at their columnar fashion and color code them. So blue and green is good, red is bad, and they can tell us when there is an impending physeal arrest or, you know, slowing of the growth plate. So I think that's another you know, application in the horizon. Okay. I don't know how we're doing with time, Malin.
Yeah, I think it's 10 minutes to 9. We have one case which Goda wanted to present.
Sure.
Maybe we can do the second. The next Saturday was a journal club plan, but we can do journal club later, and we can go with, if you have time, at the second part of this.
Well, we could talk later too, but next Saturday I cannot do it at this time.
Yeah.
But we can look for another date, or we could just hold off till Posey, and we can do them too. Yeah. But I do, while I have the audience, I want to invite you all. We do this annual pediatric limb difference webinar. It's going to be in June. I don't have the date right in front of me, but I'll send it to Molin.
Yeah, I'll
And
circulate.
Yeah. So, and that's going to be like local to global. And I think there's going to be speakers from, different parts of the world, basically talking about different strategies for, limb reconstruction in children, and also teaching and training for limb deformities. So
Right.
I'd invite all of you to attend that. Thank you. So I'll stop sharing here, Molin, if you want.
Yeah, and Goda, you can share your screen.
Yes, sir.
And so those all were interesting bunch of cases, and I'm sure that everyone learned a lot. So this case, which I did with Goda recently, this is I would say the Corona disasters. Because of COVID, we lost follow-up of many patients, and those coming from really remote areas where they suffered a lot. So this is an example of that, and you can suggest what we could have done better in it.
Yes, sir. Are you able to see the screen, sir?
Yep.
Yeah.
Okay. So we had a 5-year-old girl. She presented a few years back to sir with complaints of her parents brought her with complaints of short right lower limb, and she had deformity in the ankle as well as she had some amount of knee valgus. And her radiographs, which I'll be showing later, they showed shortening of about 5 centimeters in the right lower limb. She had knee and ankle valgus deformity, and the knee valgus was because of the femur after we calculated, and the LDFA was about 81 degrees. And her radiographs revealed that she had type 1B fibular hemimelia, acumen, and calamity. So these were her radiographs. So what we've done is we wanted to correct her valgus deformity. Hence, we've done growth modulation and specifically explained them to come back because the 8 plate has to be removed. But the patient did not present to us in spite of proper explanation and because of COVID as well. And what our plan was to correct the knee valgus in stage 1, followed by lengthening in stage 2. So post growth modulation, the patient was lost to follow-up. And she presented 5 years later in this state with ankle equinus, valgus, and this valgus has become a varus. So she has genu varum now. And this is her gait. She has about 10 centimeters shortening now. And these are her radiographs. So as we can see.
So
Yes,
Goda, you can stop there and
yes, sir.
Yes, Dr. Sanjeev. Now we have seen this overcorrection with Januvarum, but this is the most gross-tech deformity I have seen after overcorrection, and so how we should approach this problem now?
Yeah,
We'll show.
Yeah. So thank you for sharing. So I agree. Now the good news is that she still has some growth remaining, right? She's only 10.
Yeah.
Right. Yeah. Okay. So of course, if you look at all her issues, she's got sort of this overcorrection with broken hardware. She's got more severe equinovalgus distally, and of course the shortening coming from both the femur and the tibia. So you could, again, you have to set expectations, see what the family is, able to do, and what's realistic for them in terms of compliance and long-term plans. So if you look at the orthopedic goals, it is to have near equal leg lengths with near normal alignment and preservation of knee and ankle mobility, right? So with those goals in mind, things that are time sensitive are growth related. So
Yeah.
one option to consider is certainly take the plate out from the medial side. I'm sorry, from the medial side of the distal femur, and you could certainly put another plate on the lateral side to speed up getting her back to close to normal alignment. At the same time, you can do some soft tissue releases around the foot and ankle. And again, there's many ways to deal with fibular hemimelia, but if she's in severe equinus, I think some way of doing soft tissue release to get the foot in a more plantigrade position would be appropriate, plus minus a shoe lift. And then, the question is, can you do and if she's got, what was the projected leg length difference, like 10 plus centimeters?
Yes, sir.
Okay, so then I personally, knowing what the family's already been through and non-compliance, etc., if you feel they're going to be compliant, then I think closing down the distal femur on the left side with appropriate, education would certainly be on the table for me. So I think, to minimize the number of lengthenings, back and forth, physical therapy, etc. And you could almost convince me to say you could do the femur and the tibia, but, so that would be another conversation. But I think to do relatively small surgical procedures with long-term grain and to, keep her whatever growth remaining in mind and take use of it would be my sort of first 1 or 2 steps.
Yeah. So, I mean, so this time the family is too much kind of adherent to my advice. But I learned there was a paper that where growth modulation fails, so if a patient is from other province or the native language is different, this can happen. So this patient, now this paper was from States, but I think that stays true from India as well. Now this patient was from Rajasthan, and the Marwadi language, and I explained them many times that you give consent not for just one surgery but also for the removal. So that's the learning point for all the fellows. But here, Goda, how much the femur shortening was there? Femur was also quite short, right?
Yes, sir. Yes, sir. Around 6.5 centimeters. So 6 and 6 altogether, it was around 11-12 centimeter shortening.
Yeah, and the projected would be a little more than this. Yeah, so Goda, show what we did and what we planned for it. Yeah.
Yes, sir. So what we did in this case is we've done a bilateral distal femur and proximal tibia drill epiphysiodesis to stop her growth. And then to correct this deformity, this was almost a 43-degree varus. So a very huge deformity, which cannot be corrected acutely. And as well as we needed to lengthen it also. So we've done a knee spanning Elizarov external fixation with a lengthening hinge. So this is the immediate post-operative X-ray. We were not able to remove the plates, sir. So what we followed over here is a rule to osteotomy with the hinge at the cora and osteotomy at another level. And this is a lengthening hinge to gain some amount of length as well. So this is the patient on POD1. She's quite comfortably standing with a fixator on. And then we proceeded with rule of triangles, went for gradual deformity correction as well as lengthening. And these are her follow-up radiographs. Here we can see that the deformity is corrected as well as we've gained around 5.5 centimeters of length. And this was just before the fixator removal. And the fixator has been removed about 2.5 months back. And these are her latest radiographs, which show that the deformity is corrected, alignment is restored. And this is the patient. She has some amount of residual shortening as well, which we are planning to correct it in stage 2. The ankle equinus as well as residual lengthening will be dealt with later. So
So, yeah.
And she does have a stiff knee, and physiotherapy has been started to improve her knee range of movement. But all these issues will be dealt with later.
So, yeah. So, Dr. Sabharwal, would you comment on this?
Yeah, sure. So yeah, I mean, definitely, a very reasonable outcome with a decent plan. If you want me to be like looking at it educationally and looking at the X-rays again, let's go back to the
Can go
post-lengthening
back, yeah.
X-ray.
Post-lengthening
So,
X-ray.
yeah, this one's good. Yeah. So as you know, that a lot of times when you have fibular hemimelia, you also have, the congenital shortening involves everything from the hip down to the toes, right? So
Yeah.
again, for the trainees, like you need to examine the knee for ligamentous laxity. A lot of kids with, like, I think this patient also, if you have a fibular hemimelia, you'll have a component of femoral shortening as well. On top of that, as we know, a lot of these kids will have ACL, PCL deficiency. And I don't know if this is projectional or not, but I certainly see on the lateral, there is some anterior translation of the tibia. And I wonder if she has some ACL laxity, which, despite the lengthening, has contributed to her knee stiffness, right?
Mm-hmm.
So I think that would be one sort of take home. And of course, like we've discussed earlier, when you have a fixator lengthening in the femur, it binds the quad. So Malin, I don't know if this patient needed a quadriceps plasty or how much knee motion. Yeah.
So it's about, she is 3 months post fixator removal, and I'm waiting. We are working on her rehab. Her current knee flexion is around 45 degrees. So I'm waiting, and usually we give 1 year for the improvement of knee motion before we consider quadriceplasty or detethering of the pin tracks.
I mean, you
so-
could see her patella is, distalized, and I think
Yeah.
the tibia is subluxed anteriorly. So, and I'm sure you did this, but while you're lengthening, especially for congenital shortening, even if you're lengthening the tibia, and definitely when you're lengthening the femur, we got to keep an eye on
the knee joint, yeah.
knee joint and try to splint it in extension, right? Because if as you know, when the knee is in extension, it's very hard even for an ACL deficient knee to sublux. So I think to maintain knee extension is even more critical. The knee flexion, of course, is important, but to me, less important or less urgent, because you can always regain knee flexion, with or without therapy and quadriceps plasty. But to gain knee extension in a sublux joint is much, much harder.
Now, the second question is, would you wait for complete or reasonable knee flexion to come before considering tibial correction and lengthening? This child probably is now 12 years old. In Rajasthan, they want to get everything corrected before they become marriageable age. They get married very early, around 16 to 18 years, So,
Yeah.
but I'm very skeptical. We need to have good range of motion.
Yeah, totally. And, to your point, though, I think you spanned the knee joint with the fixator. And was the knee locked in extension? Like I saw a clinical picture.
Yeah.
So
the knee was in extension.
Yeah. So, I mean, that is a good thing. But if I look at it critically, even on that lateral, it's starting to anteriorly sublux a little, don't you? Don't you think so? Right?
Yeah, I didn't, I now I realize it, but I didn't have a look at that time.
Yeah. But no, so
you're probably right.
But I wouldn't be in a big rush, social reasons or whatever, because you could always make her worse, and less manageable by, giving her more stiffness. But I would I would almost correct the soft tissues around the ankle now, and even if it's in valgus, do a guided growth medially with a screw if needed, if that's part of her problem. And honestly, wait till she's skeletally mature so you know
What
what's
exact length we need? Yeah.
Yeah, and then just do it one time depending on what it is. But
Yeah.
I would focus on getting her knee moving and, you know, realigning her distal tibia and getting the soft tissues so that she's not walking on her toes all the time. And if she can, you know, use a shoe lift plus minus a AFO.
Have you ever required knee ligament reconstructions in this situation?
Oh yeah. Oh yeah. Well, I mean, we do it prophylactically. We didn't have time today to show all the cases, but that was sort of my next set of cases on how to deal with congenitally short femur. So, you know, maybe another time.
Maybe another time. Yeah.
Yeah.
So yeah, thanks Goda for that case. It's 10 past 9. So thank you everyone for patient listening. And Dr. Sanjeev, that was a great talk. And
Thank you.
we realized that there's a lot of more things we need to see very closely, very critically, besides just the x-rays and length and all. So thanks for all the lessons.
Thank you. Thank you for sharing, Malin, and thanks for the invitation. Great session. Thank you.
Yeah. Have a good day. Take care.
All right. You too. Bye-bye. Thank you.
Yeah. Bye-bye.